Hello and welcome back to Chagpar MD. I'm Dr. Anise Chagpar, and today I am joined by a very special guest. Dr. Jill Lacy is a professor of medicine here at Yale Cancer Center, and she really is focused on gastric and gastroesophageal as well as other GI malignancies. So there have been some exciting advances that have just come out with regards to gastroesophageal cancers, and I thought there would be no better person to talk to us about these advances than her. And oh, by the way, you can catch the radio show that Jill and I did on Yale Cancer Answers. It airs on WNPR on Sundays. And if you can't catch it there, check the description box below for the link. You can catch all the archives there. So thank you so much for joining me, Jill.
And thank you for having me today.
So let's start, laying the table to begin with. What exactly is gastroesophageal cancer and why should we care?
Good question. So gastroesophageal cancer actually encompasses several different subtypes of cancer. So anatomically, we have cancers that arise in the esophagus. So that's the tube that connects the throat to the stomach, and then cancers that arise in the stomach. And in the esophagus, we have two subtypes. One is called squamous, that we think about as a cancer almost similar to throat and head and neck cancers. It's linked to alcohol and tobacco. Fortunately, the incidence of that cancer is declining dramatically in the Western world. And then we have a second subtype called adenocarcinoma that is much more similar to stomach cancer and actually anatomically generally starts right down at the bottom of the esophagus where it connects to the stomach. And then we have cancers that arise in the true stomach, and those under the microscope all look like adenocarcinomas. So it is a somewhat heterogeneous group of cancers that is often lumped together.
And so when you talk about the incidence worldwide, how common is this? You mentioned that the esophageal cancers are declining. Are we seeing similar declines in stomach cancers too?
Well, there's some really interesting epidemiological phenomena that are going on with these cancers. So gastric cancer up until the 1980s or 1990s was the #1 cause of cancer-related death globally.
Wow.
Globally, the incidence is going down and the death rate's going down because of that. So now it's dropped to 3rd place, but it's still a huge threat globally. In the United States, the incidence of gastric cancer has been going down for probably almost close to 100 years. And it's not a common cancer. There are only about 27,000 cases a year and 11,000 deaths. So it's certainly not one of the most common cancers, but it still has a high mortality for those that are diagnosed. Esophagus cancer, about 500,000 cases globally, so still also a big public health threat, and is the 6th most common cause of cancer-related death globally. In the United States, again, not a common cancer, about 18,000 cases, a little bit more lethal than gastric cancer because about 16,000 patients die per year. So the death rate starts to approach the case rate. And it is important to keep in mind that esophagus cancer still is a pretty significant issue, particularly for males. There is a male preponderance, and it's the 7th leading cause of cancer-related death in males, even in the United States. Wow. So there's a lot of geographic variability in incidence and mortality with these cancers.
That's interesting. I don't think that many people would realize that gastric cancer particularly was such a global cancer issue. Why is that? Why are there so many cases of gastric cancer? Is there some etiologic factor that is more prevalent perhaps in the developing world than it is in the United States that makes it so much more prevalent? The incidence must be so much higher in the developing world than it is in the US if it's not very common here, and yet it's the 3rd leading cancer worldwide.
Yes, so the most common etiologic factor for gastric cancer is chronic inflammation of the lining of the stomach. There are a couple of reasons that someone can have that, but the most common cause of chronic inflammation of the stomach is actually a bacteria that many folks around the globe are colonized with. It's very prevalent, very common, and that bacteria is called Helicobacter pylori, or H. pylori. That's probably the number one cause of gastric cancer around the globe. Diet plays a role. Increasing weight or obesity, which is a risk factor for many cancers, is a modest risk factor for gastric cancer. And we do see that the likelihood of carrying Helicobacter pylori in your stomach starts to go down as countries develop, and that probably relates to food preparation and refrigeration and food preservation techniques. So we do see that as the incidence of H. pylori goes down, that goes hand in hand with gastric cancer going down. But there's another sort of interesting twist to the story in that there's one type of gastric cancer where the incidence is going up quite dramatically, and in fact we call it an epidemic, and that's cancers that arise anatomically right where the esophagus and the stomach come together. We call that gastroesophageal junction cancers. So that encompasses cancers at the bottom of the esophagus, at the junction, and at the top of the stomach. And there is a bit of a mini epidemic of that in the Western world, particularly in Caucasian males. And there is a theory that H. pylori eradication, which protects people from stomach cancers, actually increase the risk of these gastroesophageal junction cancers. That is a theory. So again, some really interesting epidemiology in regards to these cancers. But I think the good news is globally, the mortality is declining for gastroesophageal cancers.
Yeah, it's interesting that you mentioned the G junction cancers being related to H. pylori eradication, because one of the obvious questions that I'm sure our viewers might be thinking about as well, and certainly I was thinking about when you were talking about the incidence of gastric cancer globally, is, well, has anybody tried a public health initiative? If H. pylori is such a major issue in terms of people being colonized with it, particularly in the developing world, and that leading to gastric cancer, which is now the third leading cause of cancer globally, simply to eradicate H. pylori. I mean, we have the antibiotics to do that. But I guess the downside to that strategy may be this increase in G junction cancers. Is that right? Or have people actually tried to eradicate H. pylori, or is there benefit to that?
That's really debated in the field, whether mass public health eradication programs will impact favorably on incidence and, most importantly, mortality. I think it's still an unsettled issue, actually. So I think ongoing studies and more data are needed.
Wow, interesting. Okay, so let's talk about this mini epidemic. So we're starting to see more GE junction tumors, which may be related to H. pylori eradication, which, I mean, is kind of like you're damned if you do and damned if you don't. So what are we doing about GE junction tumors? I mean, how do we diagnose it? Is there anything we can do to prevent it, short of not eradicating H. pylori, which then increases your risk of gastric cancer? Where do we stand with this?
So that's still hypothetical, but there is some evidence to support that phenomenon of H. pylori eradication. So GE junction cancers, I think we do understand a little bit about risk factors. So one is chronic gastric esophageal reflux disease, or heartburn. And we can talk a little bit more about that because that's very common, and certainly don't want people to be frightened by that. And then the other risk factor, again, true for many cancers, is high BMI and obesity. Smoking is a very modest risk factor. Alcohol does not seem to be a risk factor. And then demographics, it tends to afflict predominantly Caucasian males around the age of 60 to 70. That is the demographic. It's much less common in women. But we do know that GERD is a risk factor, gastroesophageal reflux disease. And the reason for that is that acid refluxing into the esophagus can, in some cases, change the lining of the esophagus to look more like the stomach. We call that Barrett's esophagus. And Barrett's in a very small percentage of patients can evolve into a more pre-malignant appearance and then ultimately invasive cancer. But I would highlight that GERD is very common. Only probably about 10% of patients with chronic, and we're talking about, multiple times a week needing to medicate, only about 10% develop Barrett's, and of those, only about 0.5% per year go on and develop cancer. So in terms of what we can do, again, this is another unsettled area, but there are some emerging guidelines about screening folks who may be at increased risk by virtue of, male, a little bit older, chronic reflux, and whether, those patients should be undergoing a screening endoscopy to look for Barrett's. If you find Barrett's, then those patients would be subjected to sort of a regular endoscopy program for screening.
And so if the gastroesophageal cancers are really affected by acid reflux, which goes hand in hand with obesity, right? More obesity is a risk factor for gastroesophageal reflux. And if it is that the acid is really affecting the lining of the esophagus, do reflux medications, antacids, things that suppress the acidity benefit for people who have reflux?
Yeah, I think there is emerging evidence that treating the reflux disease is important. There's also some evidence that treating the reflux disease with this class of drugs called proton pump inhibitors, which are very common, you can buy them over the counter, in combination with aspirin, can reduce the likelihood of developing invasive cancer if in fact you have Barrett's. So it's very important for these patients to be working very closely with their gastroenterologists about managing this entity and reducing their risk factors, with some lifestyle interventions and possibly medications.
Yeah, especially as we see obesity rise worldwide, this and other cancers just seem to skyrocket. As I think about that and think about low resource settings. So certainly, in the Western world, in the United States, endoscopy is very common. It's ubiquitously available. And people can pass the scope down and see the changes in the lining of the esophagus and biopsy it and make the diagnosis. In some parts of the world, people have started talking about this concept of a sponge on a stick, a kind of a sponge that's put down the esophagus that can then get cells or DNA that can provide a diagnosis. Is there any merit to any of that?
Yeah, so in areas of the country where there's a very high incidence of either esophageal cancer or gastric cancer, so esophageal cancer, we talk about an esophageal cancer belt that stretches from Iran across Central Asia. There are screening protocols for esophagus cancer that can involve either that technique where you swallow a sponge or a balloon and pull it up and scrape off the cells and look at them under the microscope. So it's sort of analogous to a pap smear, looking for abnormal cells. They also can do endoscopy. Obviously, endoscopy, is a little bit more resource intensive. And then similarly, in areas of the world where gastric cancer incidence is high, such as South Korea and Japan, they do actually widespread screening there as well. And that can be either a radiographic study, swallowing barium and looking at the lining of the stomach to see if it's irregular, or endoscopies. And there is, I think, pretty good evidence from those areas of the world that screening has a favorable impact on outcome. You can pick up the diagnosis earlier, and that can lead to a higher cure rate and a lower mortality. But in the United States, we don't do mass screening. It's targeted screening based on risk factors, such as what I just mentioned in terms of your risk for Barrett's. Sometimes we screen patients for gastric cancer, if they have risk factors that might mandate screening. But it's very targeted screening. There's no mass screening as we have for lung cancer, breast cancer, colorectal cancer.
And that's because in parts of the world like Korea and Japan, just simply the incidence is higher, we think, because of geographic or racial considerations?
Yeah, I mean, again, a lot of unanswered questions. Some of that is higher rates of colonization with H. pylori, some of it's diet, some of it may be hereditary influences that are, related to ethnicity. But there, the incidence is high enough that in terms of cost effectiveness issues, it makes sense to do more widespread screening.
And so back to the United States. So if patients have risk factors, they can potentially get screened and diagnosed that way on endoscopy by biopsy of Barrett's or of a gastric lesion or whatever. If they don't have risk factors, are there symptoms and signs that they should look at that would predispose them or that might be a signal for gastric or gastroesophageal cancer?
Yeah, so for the tumors that are in the esophagus, including at the junction of the esophagus and the stomach, the most common presenting symptom is difficulty swallowing. Food just doesn't go down smoothly, kind of hangs up, gets stuck. That is, I think, the number one presenting symptom. Sometimes it's just worsening of chronic reflux disease or new onset severe reflux disease, or sometimes it's a bleeding episode. The tumor ulcerates and they vomit blood or notice blood in their stool. Stomach cancer can present in the same way, may present with pain, dyspepsia, indigestion, decreased appetite, filling up quickly, sitting down to eat, and after a few bites being full. If the tumor is more advanced and widespread at diagnosis, so what we call stage 4 disease, then there may be more what we call constitutional symptoms, fatigue, weight loss, not wanting to eat at all. So those are ways in which these cancers do present.
And so, as you think about treatment of cancers, I mean, often in this show, as well as on the radio, we talk about kind of 3 legs of a stool that often go together in terms of cancer management: surgery, medical management with chemotherapy or other systemic therapies, and radiation. But when you think about gastroesophageal cancers, you think about, that food pipe to your stomach is a pretty important organ. So how do we treat this? I mean, is surgery the mainstay? Do we treat this primarily with medical management? Does radiation play a role? How do we kind of approach this? Because it's not like, you can remove it without consequences.
Yeah, that's a really important point. The esophagus is very important for our nutrition and our quality of life. So we have to be thinking about how our treatments affect that function. So as is the case for so many solid tumors, at diagnosis, we do our staging evaluation to see if there's any distant spread. And if the cancer is localized, we often, as is in the case here, have a path to cure. And as is often the case, surgical resection of the tumor plays a pivotal central role. And those principles apply here. For patients with very early stage disease, a tumor that's very shallow and doesn't go deep into the wall, and there's no evidence of spread to lymph glands or anywhere else, it is a surgical disease. And my surgical colleagues, do what they do and cure many of those patients. If it's more advanced, if the tumor is deeper into the wall or there's regional lymph node involvement, but still no distant metastases, there's still a path to cure. Surgery is still a centerpiece of that, but in addition, we need other therapies, adjunctive or adjuvant therapies. For esophagus cancer, sort of historically, in the way the treatment has evolved, in those patients, we would start with a combination of chemotherapy and radiation, and then move on to surgical resection. And for stomach cancer, it's a little bit different. We tend not to use radiation there. There, the adjunctive therapy is chemotherapy, either after an upfront operation. That's generally how it's managed in Asia. In the Western world, we give some chemotherapy before and some chemotherapy after surgery. So many of those patients with this combined modality therapeutic approach are cured.
It's interesting that there are differences in how this is managed in Asia versus in the US. I mean, has anybody done definitive trials to kind of say, is it better to do chemotherapy afterwards in the adjuvant setting, or is it better to do the kind of sandwich neoadjuvant surgery adjuvant technique? I mean, that should be a relatively simple clinical trial, I would think, that would give you a definitive answer, and then everybody can be doing whatever is the definitive answer.
Yes, we wish we had that data, but that study has not been done. And I think as you know, in your field, our practice is driven by the evidence. And there is this phenomenon with gastric cancer that it does seem to have a different biology in the Eastern world versus Western world. The prognosis stage actually in Asia for gastric cancer is better. So that relates to the inherent biology. And so there always is an issue when you're doing clinical trials with gastric cancer. And this is not true for all cancers, but it's true for gastric cancer. You have to look at where the study was done and are we sure we can apply that to your region? So in the Western world, the way the study was designed for stomach cancer was to give some chemo before and some chemo after. And in Asia, the way they've designed most of their studies is to do upfront surgery and then give the chemo afterwards. It may not matter. We don't know. If I had to bet, I would say it probably doesn't matter how we sequence. There are some situations where we have to do surgery first. The patient's bleeding, or they've had a perforation, a hole in the wall, or their stomach is just blocked up. They can't get food through, and it kind of makes sense often in that case to just go and do surgery first and give the chemo afterwards.
So it's interesting that the biology is different. I wonder, has anybody actually looked at the genomic profiles of these tumors from Asia and compared it to the Western world to actually see, like, are these tumors different, biologically different? Are they driven by different drivers? Because one could surmise, right? Like, the world is shrinking, and we know that more now than ever before. People move around, and so you may have been in Asia all your life, developed your gastric cancer, but have moved to the US. Your biology is still presumably your biology, although you're in a new geography. So I just wonder whether we've kind of unlocked why these tumors behave differently.
It's complex for sure. We know that. I think it's both environmental and there may be a genetic overlay. So we know there are different molecular subtypes of gastric and esophageal cancer, and that work is evolving very nicely. And we do know that some subtypes just inherently are less aggressive and have a better biology. And in Asia, there's a greater enrichment of those subtypes in the population. Some of that gets back to H. pylori, again, because the subtype that's most commonly associated with H. pylori, so-called intestinal subtype under the microscope, tends to have a better biology as opposed to some other subtypes that we know are very aggressive. But I think it is a complex interplay of both environment and genetics. It's not simple. I think ultimately we're going to be coming down to molecular profiling of all tumors and seeing where patients fit in terms of what type of tumor they have. And hopefully that will then begin to lead to more specific therapies for each molecular subtype of gastric cancer. So gastric cancer, even though anatomically it's all in the stomach, even under the microscope, there are different subtypes. And then at the molecular level, there are a number of subtypes that we're now beginning to define.
Yeah. So you talked a little bit about local disease and local regional disease. Talk a little bit more about metastatic disease. I understand that there are some really cool advances, new advances in terms of how we treat metastatic disease. which is always exciting because whenever patients hear the word metastatic cancer, it sends a shiver down their spine. And so anytime we have new data about promising results in that space, that's always hopeful information for patients and their families to have.
Yes, I think we're really on the verge of a big giant step forward in the treatment of advanced or metastatic incurable gastroesophageal cancers. So, so there was a bit of an advance over a decade ago for one subtype of gastroesophageal cancers called the HER2 positive subtype. So about 20 to 30% of gastroesophageal cancers, and this is the adenocarcinomas, I'm not talking about squamous cell of the esophagus, will have on the surface of the cancer cell a protein called HER2, which we identified in the breast cancer world a few decades earlier. And that is a protein for which we have had a targeted therapy, and now several targeted therapies for many, many years. The first targeted therapy was a drug called trastuzumab or Herceptin, and that has been utilized in HER2 positive breast cancer, as you well know, with just dramatic positive results, both in the advanced setting and the localized setting. So obviously it made sense to test Herceptin or trastuzumab in HER2 positive gastroesophageal cancers, and that study was done where patients with stage 4 advanced disease were given standard chemotherapy, which was the standard of care, or standard chemotherapy plus Herceptin or trastuzumab. And that was a positive study and very exciting, significantly extended survival by several months. So not the big advantage in terms of survival benefit that we see in breast cancer, but definitely progress. So in that subset of patients now, the standard treatment is chemotherapy and trastuzumab. And I think the big breakthrough that's coming is in second and third generation drugs that target that HER2 protein. Now, in breast cancer, there are several of those that are being used with great efficacy. In gastroesophageal cancer, some of those drugs haven't worked, but we're now, I think, on the verge of discovering some newer HER2 targeting agents that are going to be very effective in this 20 to 30% of patients. So for the HER2 positive gastroesophageal cancers, we're very excited about some of these newer drugs. I'll mention one. It's what we, in the class of drugs, called an antibody drug conjugate. So the antibody is Herceptin or trastuzumab that targets HER2. And then you hook up to that a very powerful chemotherapeutic agent. And so the antibody goes to the tumor in a very specific way and delivers that payload. And that there is an antibody drug conjugate that has just been approved in breast cancer called trastuzumab deruxtecan that looks very promising in gastroesophageal cancers in patients who've already had trastuzumab and need something else. That I think will likely be approved within the next year. And we're super excited about the data with trastuzumab deruxtecan. There are other second and third generation trastuzumab-like antibodies that are being developed. And then I think there's also very exciting preliminary data that if you combine trastuzumab or similar antibodies with immune checkpoint inhibitors, you're really getting impressive results. So the field is very promising for the HER2 positive patients, 20 to 30%, so a significant chunk of our patients. There's excitement, though, for the remaining 70 to 80% as well. And this is very, very recent data, just from the last 2 months, in using immune checkpoint inhibitors, so immunotherapy. Of course, we've heard so much about these drugs in other cancers, especially lung cancer, melanoma. They've been a little slow to have an impact in gastroesophageal cancers, but I think it's just in part because of the way the studies were designed. But what we learned just a few months ago is that for, again, patients with metastatic, both esophagus and gastric cancers, generally we're going to be giving them chemotherapy. If you add an immune checkpoint inhibitor to the chemotherapy, we do seem to be significantly prolonging survival. So that approach is not yet FDA approved, but we do expect that that will be coming in that patient population as well. So we are very excited about these advances, and I think it's really just the beginning. I think we're going to see more positive results for this patient population.
That's tremendous. Is the effect with the immune checkpoint inhibitors only if patients' tumors express PD-1 or PD-L1? I mean, because in some cancers, it doesn't matter whether or not there is expression of that immune checkpoint receptor. The immunotherapy works regardless for some reason, and in some, it's very specific as to, if you don't have that, then the drug isn't going to work. How does that work in gastroesophageal cancer?
Yeah, so this is an evolving area. We hear about PD-L1 on the advertisements on TV, where they talk to patients. Ask your doctor if your tumor expresses PD-L1 and you may be a candidate. So it's front and center of the story with the current generation of immune checkpoint inhibitors, Keytruda, Opdivo. Does your tumor have PD-L1? Does it matter? The pivotal questions. It does appear, and again, this is not fully settled, in gastroesophageal cancer, that the higher the level of PD-L1 on your tumor, the more likely it is that you will derive significant benefit from these agents. What we still don't know, is there any benefit? Is there no benefit in patients whose tumors have no PD-L1? And then how about those patients who have a little bit of PD-L1? Their levels are low. Do they derive benefit, and how much benefit? In terms of the data that was presented, we can't tease that out. What we know is that in both of the studies, one looked more at esophagus and the other at stomach plus esophagus, that all comers, regardless of PD-L1, benefited. But what we don't know is that the benefit in all comers was really just driven by those patients who had high PD-L1. So this is an unsettled, really important question that you're asking. We'll get there, but I don't think we know the answer just yet.
Such cool information, and it's so nice to hear that there are these targeted agents and new therapies on the horizon for what is remarkably a common or fairly common phenomenon globally. So thank you again for being my guest here on CHAGPAR MD. This has been such a wonderful show learning more about gastroesophageal cancers. For all of you out there, I will leave Dr. Lacy's contact information and bio in the description box below. I hope that you will like, share, and subscribe. Please give this information to somebody that you think may benefit from it. And if you have other questions and want us to cover other topics, let us know. Until next week, this is Dr. Anise CHAGPAR wishing you all a safe and healthy week.